Approaching a patient with transient loss of consciousness, TLOC, following a history of road traffic accident, RTA, requires a systematic assessment to identify the cause, evaluate the severity, and guide appropriate management. Here's a detailed approach. Number 1. Initial assessment, primary survey. The priority in trauma patients is to identify and manage life-threatening conditions. Airway with cervical spine protection. Ensure the airway is patent. Protect the cervical spine using a collar or manual stabilization. Assume a cervical spine injury until proven otherwise. B. Breathing and ventilation. Assess for adequate oxygenation and ventilation. Look for chest rise, cyanosis, or abnormal breath sounds. Provide supplemental oxygen if needed. C. Circulation with hemorrhage control. Check for signs of shock, tachycardia, hypotension, pallor, cool extremities. Control active bleeding and establish 2 large-bore intravenous IV lines for fluids or blood products if indicated. D. Disability, neurological assessment. Perform a Glasgow Coma Scale, GCS evaluation. Evaluate motor, verbal, and eye-opening responses. A GCS score of 8 indicates the need for airway protection. Check pupils for size, symmetry, and reaction to light. E. Exposure and environment. Fully expose the patient to look for injuries, but prevent hypothermia. Number 2, secondary survey, detailed evaluation. Conduct a thorough assessment after stabilization. History, ample framework. 1. Allergies. 2. Medications. 3. Past medical history, e.g. seizures, cardiovascular disease. 4. Last meal, important for surgery or anesthesia. 5. Events leading to the injury, mechanism of RTA, speed, impact, etc. Specifically, ask about the nature of TLOC. Duration. How long was the patient unconscious? Onset. Did it occur immediately after the accident, or was there a delay? Witness account. Were there any abnormal movements, e.g. seizures? Recovery. Was it complete or partial? Preceding symptoms? Dizziness, chest pain, palpitations? Physical examination. Assess for focal deficits, e.g. weakness, altered sensation. Look for signs of raised intracranial pressure, e.g. papilledema, Cushing's triad. 2. Head and neck. Inspect for scalp lacerations, skull deformities, or bruising, e.g. battle sign, raccoon eyes. 3. Chest, abdomen, pelvis. Palpate for tenderness, assess for bruising, and auscultate for abnormal sounds. 4. Extremities. Check for fractures, deformities, and peripheral pulses. Investigations. Immediate imaging. See indicated for any suspicion of traumatic brain injury, e.g. GCS-15, amnesia, vomiting, focal neurological signs. Cervical spine x-rays or CT to rule out spinal injury. Chest, abdomen, pelvis imaging if thoracic or abdominal trauma is suspected. Laboratory tests. Complete blood count, CBC, check for anemia or infection. Electrolytes and glucose to rule out metabolic causes of TLOC. Coagulation profile in cases of suspected hemorrhage. Toxicology screen if intoxication is suspected. 4. Differential diagnosis of TLOC and RTA. Traumatic causes. Traumatic brain injury, TBI, concussion, contusion, or intracranial hemorrhage. Cervical spine injury, leading to neurogenic shock or secondary brainstem involvement. Hypovolemic shock, due to internal or external bleeding. Non-traumatic causes. Seizure could be the cause or result of the accident. Cardiac arrhythmias. Syncope, due to arrhythmias like ventricular tachycardia. Vasovagal syncope, triggered by stress or pain. Metabolic derangements. Hypoglycemia, hyponatremia. Manner 5. Manidiate. Stabilize life-threatening conditions, airway, breathing, circulation. Administer fluids, blood products, or medications as indicated. Definitive. Neurosurgical consultation if intracranial hemorrhage or significant brain injury is detected. Orthopedic intervention for fractures. Cardiology referral if a cardiac cause is suspected. Observation. Admit the patient for close monitoring of neurological and vital status. Repeat GCS assessment and imaging if the patient deteriorates. Number 6. Documentation and communication. Clearly document the findings, interventions, and patient progress. Communicate effectively with the patient's family and trauma team about the condition and management plan. This comprehensive approach ensures a systematic evaluation and management of patients with TLOC following RTA.